This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street. Well, welcome, folks. Dr. Charles Parker here one more time, and we have a very interesting, perhaps somewhat controversial guest here this afternoon. He shouldn't be controversial as far as I'm concerned, but he is surely controversial in terms of how some people think addiction medicine should be practiced in this country, internationally, and Dr. George Bright has some very strong opinions about what needs to be done in that juxtaposition between addiction medicine, recovery, and ADD, executive function problems. Welcome aboard, George.
Thank you very much. I look forward to this discussion, and hopefully we can shed some light on ideas that we've developed over a period of time and what seems to work for a population of at-risk people. So, a little bit of background about my experience. Actually, I started out as a pediatrician and then went to the military and then to Children's Hospital in Boston for a fellowship in adolescent medicine. Part of that training was with the chief of psychiatry at MIT and Harvard, and then began to work in the field of substance abuse, and that was in the late 60s. Was able to join the faculty at the Medical College of Virginia and start the adolescent medicine program, and actually started the first methadone program in 1972. So the background has been in developmental pediatrics and then developmental medicine for children, adolescents, and now a large percentage of our practice is adults. When we look at the area of addiction, we looked at just in the area of opiate dependence at about 300 patients. And we used the DSM-4, DSM-5 criteria to look at the other co-occurring problems. And interestingly enough, we find that approximately 60 to 70% of those opiate-dependent people met the criteria for an attention deficit disorder. When we look at chronic pain, and we have a large number of people who have chronic pain, they also meet that criteria in about 60% for attention deficit disorder. But there are other co-occurring problems that really fit into what we see, and that is social issues. Molestation is also a prominent issue. When you look at how to approach this population, it's important to look at them as a whole person. When you look at their home, their developmental history, their school history, and how that impacts their substance abuse, let's go back a little bit and look at children. Children who have an attention deficit in elementary school frequently do not get the building blocks they need for middle school. They may feel differently socially and certainly academically. And then when they get into middle school, the number one concern of that population is peer group acceptance. If you don't measure up into your own expectations academically and you feel somewhat isolated socially, then you begin to look for peers who feel the same way you do. So what do you use as a social lubricant? In our culture today, it's primarily marijuana. Marijuana interferes in three areas of their brain: their short-term memory, motivation, and makes them a little bit more emotional to live with. If you already have an attention deficit, we know that short-term memory is a part of that profile. Therefore, as they go through middle school, they may not continue to gain academically and still feel socially isolated. Getting into high school, where there's a lot more pressure on them academically, leads to many of them dropping out, increasing their drug use, and we feel quite definitely that marijuana is a gateway to other drugs. Therefore, they may choose to use a more upper drug like cocaine, or they may choose a downer such as pain pills and opiates. When they come to us, they're usually in trouble with the law. They may be in withdrawal. So we spend about an hour to an hour and a half getting that very developmental history from them and their family members, if there is a family member, if it's an adolescent or a young adult. and then decide on a treatment plan. That treatment plan involves two major approaches: pharmacotherapy and psychosocial support. Pharmacotherapy, we use a medication called Suboxone for medical withdrawal. And then if we can get them to agree, we'd like to get them on an antagonist. And that antagonist would be a medication called naltrexone, either as a pill or an injectable called Vivitrol.
Now, George, let me stop you for just a second, because tell our audience what type of addiction you're talking about there. I know, but I don't think they know, because that particular type of detox goes with a particular type of problem.
Right. We're talking about opiate dependence.
Good.
And for alcohol dependence, then the medication that we're talking about is an antagonist, is the Vivitrol, which is an injectable depot naltrexone for once-a-month injection. And it completely blocks their cravings. It goes to a receptor in the brain that releases dopamine with the use of both alcohol and or an opiate. It is more specific for the opiate blocker, but it also reduces your interest in drinking because it reduces the release of dopamine. That is one form of the pharmacotherapy. But there's another aspect of this. If the underlying problem started out as an attention deficit, then we feel that you treat concomitantly those co-occurring problems. So we use stimulant medication when there is a DSM-4 or DSM-5 criteria for an attention deficit disorder. Currently, we're using a new medication. It is called Adzenys. It is an XR, oral dissolvable tablet, that I have found to be very effective in several ways. Many of the stimulants that we use will give you a bit of a buzz, a little bit of a high. The medication that I'm talking about does not give that bump, as they call it, in the morning. It is less likely to change the personality, as some of these stimulants will blunt the personality, and teenagers don't like to use it. The other side effects that we frequently see with a medication like this is sleep problems or anxiety, or even appetite suppression. And oftentimes there's an afternoon rebound irritability. Therefore, I'm not finding that. And also, the abuse potential is a great concern. If this product is tried to be crushed and snorted, it becomes a gelatinous mass, and it burns the mucous membranes because it has citric acid in it.
There's a point.
And it can't even be activated until it gets to the stomach, where the acidity releases 50% of the immediate release product. The other 50% is released in the small intestine with a pH of 6. So I feel quite confident, after doing the addiction medicine for approximately 40 years, to treat both medically, or the pharmacotherapy, with an antagonist, or with the maintenance medication of Suboxone or buprenorphine products, but also adding in the stimulant medication to help with the ADHD. That is not to say that there are not other co-occurring problems that need to be addressed. But it's also interesting to look at the ADHD, because the three most common findings are anxiety, depression, and sleep issues. You also find that with other co-occurring problems. But when you look at treating ADHD, if you treat the ADHD, then you're less anxious because you're able to perform to your true potential in many areas. If you're less anxious, then you tend to be less depressed. And with stimulant medication, about 25% of people will sleep better because it turned your thoughts off. So the pharmacotherapy and the psychosocial, AA, NA, individual, family work, is an important part of that rehabilitative process. One thing that we do that I'd like to mention, and I find a passion for, is a therapeutic outdoor program started in 1980 when I was still on the faculty at the Medical College of Virginia. It's called Blackwater Outdoor Experiences. It's based on Outward Bound. We put young people in two age groups, 14 to 18 and 18 to 28, in the out of doors for 3 weeks. Canoeing, hiking, backpacking, a 3-day solo, rock climbing and rappelling. We only take 6. And when we couple that with the therapy that the office provides with the families for a minimum of 2 hours a week, either in person or on phone, and the therapist in the field is talking with the therapist in the office, the change in these young people's orientation as to why they are in trouble, why they were using a product such as an opiate or marijuana or alcohol. The end of this trip is pretty powerful because it involves a parent weekend where the families come together and they do a lot of work. But we come up with a treatment plan for aftercare, and that's modified throughout the trip. And then I go out on Sunday morning and we meet with the family, the staff, and come up with the aftercare planning, which usually involves a contract between the parent and the student, a medication, a referral to another source if it's needed. And it's been a very powerful program over these many years. That is an overview of what we try to do with those young people who are at risk from substance abuse, from ADHD, and the combination of those chronic problems together. So maybe that would be a good start, and I would wait for your response.
Oh, George, it's a great start. A number of questions come up that I know our listeners would be interested in hearing. But first of all, let me compliment you, because I think that it's just plain old downright courageous for you to take a position like this, because having worked in addiction medicine for years myself, and when we met, I was running the addiction treatment center over at Peninsula Hospital, and I met George a long time ago. We figured that it was probably back in the 80s. He was the medical director at Cumberland Hospital, a residential hospital between Hampton Roads and Richmond, and we had a good fellowship right off the bat, and we've hung out on the speaking circuit for a long time, and I went the other way. I got away from addiction medicine just because this whole complexity of what George is dealing with I just couldn't deal with it in the institutions that I was involved with, because we saw this. I totally agree with George. It's been my experience, and I just want to send him a long distance high five, because I think he's really doing outstanding work there. Now, the next thing I want to ask George is, when you have co-occurring conditions like that, let's talk about that at Zenith just a little bit. I think everybody here pretty well has a good idea of the side effects that occur with straight amphetamine products. And as you know, George, and I'm sure you've thought about this, the amphetamines are, generally speaking, and there's a specific book by Salanto on this, Addiction Medicines and Stimulants. Stimulant medicines for ADD, and it talks about the comparisons between methylphenidates and amphetamines, and she's a strong proponent of all the studies that the efficacy is a little bit better with amphetamines. And as you know, some people can't take amphetamines, but laying that aside, let's just talk about this medication a little bit more thoroughly. Honestly, I'd like you to teach me what you were talking about, some of the issues of how it works, the duration of effectiveness, and what is it you find interesting from a psychopharm point of view that sets this apart from straight amphetamines?
I think the difference is the amphetamine, particularly the Adderall products or the XR, has a salt attached to it. This does not have a salt attached to it. This is just a straight
dexedrine.
No, it's a straight amphetamine, and it's a 3-to-1 dextro to levo amphetamine.
Oh, okay.
It is, the bioequivalence study was done with Adderall XR, and it is exactly the same in terms of the bioequivalence with Adderall XR. But the formulation of 200,000 microspheres with 50% ion infused in the immediate release and in the extended release, I firmly believe is the difference in the efficacy, safety, and the tolerability of this product. And I'm using it first line because of the reasons I mentioned: fewer side effects, duration of effect, less likely to be abused, and the smoothness of onset. Some of my patients will say, is this really working? Well, what do you mean, is it really working? Well, I don't get my bump in the morning anymore. Well, that bump in the morning, for those people who have children, I'd like to mention this idea that when small children are put on immediate release, they do feel a little bit of a rush, a little bit of a bump. If there is a family history of substance use disorder in any shape or form, I think this may program these children because it makes them feel better, although that is not the efficacy that you're looking for when you're treating an attention deficit disorder.
So true.
And when we did the clinical trial for Adderall XR, you mentioned that many people prefer an amphetamine as opposed to a methylphenidate. I asked every mother that came into the study, at the end of the study, what is the difference in the methylphenidate and the amphetamine? And pretty much universally, they said there's a difference in my household. My children are easier to live with. When I look at why, what I really believe, when you look at ADHD, there's a dysregulation in the frontal cortex of the brain of two brain chemicals, dopamine and norepinephrine. Dopamine is more the focus and concentration. Norepinephrine is more the emotional control. I believe that there's more efficacy and a little bit more robust effect on both compared to the methylphenidate, which is more dopamine and maybe less norepinephrine. So what we really want is a product that doesn't give you the bump, that helps with those symptoms of ADHD, and that doesn't really cause the normal side effects that many people complain about.
So now talk about the microspheres a little bit, George, if you will, because that's a new term for some people. What in the heck are microspheres? What's that all about?
Well, the microspheres are just what I'm talking about. They're very, very small particles that are, they are about 200,000 of them. And when you look at this just from a standpoint of a presentation, they're unbound amphetamine is infused into the microparticles with 50% of those that are immediate release, and then 50% of those that are coated. And that is the difference, I believe, because when you look at an Adderall XR, it's about 250 little pulvules. This is 200,000 little microparticles.
Gotcha. Completely different then. And so
it's a completely different product.
And so it's then, as a result of that, you're going to have less of a rush because all of these things are the timing situation in terms of the way they're actually metabolized is not going to be so dramatic because you don't have that large pop right there, and that's correct.
And you certainly get that large pop with the immediate release products.
Well, that's very interesting. Now let's ask this other question: how do parents work with you? Are parents coming to see you who have adolescents and children, or even young adults for the Blackwater program? How are people coming to you in terms of their preconception about the validity of using stimulant medications for addiction recovery?
When you take a developmental history from a family, from an early childhood development, and you find that there are two types of ADHD, the inattentive and the hyperactive impulsive. There are a whole list of symptoms, but children who are inattentive, they have difficulty following instructions or completing homework. They have trouble listening. And the hyperactive impulsive, they fidget. They have trouble remaining seated. They blurt out answers in school. And when that continues over a period of time, and actually there's a little screen that we do that has the normal executive functions of the brain at the top. And at the bottom are all the symptoms of ADHD, and this is fun to do. And any of your audience is interested in getting a copy of this, I'd be more than happy to send it to them. Here's what the fun is. In the waiting room, I will give the parent or parents a copy of this, and I say, I'd like you to check off at the bottom half how many of these symptoms apply to your child. If the child is old enough, I'll ask them to do the same. And I say, now, this is a cheat sheet, and you cannot compare answers until you've completed it. It is incredible how many of the answers are so similar from a parent or parents and a child, an adolescent, or a young adult. And that way we have the beginning of the information, taking the developmental history of school, their social, how they interacted socially. And another point I ask, how do you learn best? By seeing, by listening, or hands-on? And most ADHD kids will say, well, either hands-on or I'm a visual learner. A couple of other questions. In school, how many times do you have to read a paragraph to get its full meaning? Many ADHD people, children, adolescents, and adults, have reading comprehension problems, and they have to read it more than once. And in math, frequently they do better in math because math tends to be more of a right brain subject. Do you write in print or cursive? Now, most schools now don't teach cursive, they teach print. But when you look back at the cursive, that is a difficulty with ADHD people because it's a visual motor integration skill, and the print is a gross motor skill. Another question to ask kids, in particular boys, how did you do with Legos? Which gives you a clue about their visual motor skills. So these are just little screens that we do, but we also have 2 full-time psychologists, and we do a complete evaluation, which includes the cognition, which is the Wechsler or the WACE. We look at achievement with the Woodcock-Johnson psychoeducational test battery. And then we also try to look at personality characteristics using some projective testing. You put all that together, and then you have a profile. And that profile is pretty accurate in terms of an attention deficit.
Well, that's great, George. Let me ask you this question. Sorry to interrupt you there. You were taking a breath. You can't take a breath when you're working with me, George. So I want to ask you this I was busting to ask you this other question because I think one of the things that listeners are concerned about, because they're going to have a natural concern about stimulant medications. They're going to read from the FDA that they're addictive. What kind of problems have you had, George? Have you had any problems at all? Then what did you do about them when you've hit the problems with either the parents thinking or the kids using, or what? How's that play itself out?
I think it depends on knowing the family. And knowing the family, one other thing that we have done, just to be sure that somebody is not going doctor shopping and finding other doctors to prescribe, is a prescription monitoring program. And we do that prescription monitoring program on everybody who's on a controlled substance, a C2. We do it with every prescription refill, every visit, and also, just because I do addiction medicine, we do a 12-panel drug screen on everybody 12 years of age and older. Families know when kids are doing something they shouldn't, but we have to confirm that the family's not doing something that they shouldn't as well. Therefore, the PMP, as we call it, the urine drug screen, a complete follow-up on school, home, relationships, and activities. You know, a medical follow-up is not, here's a pill, how you're doing. A medical follow-up is being comprehensive and looking at the whole picture. Yes. School, home, activities, relationships, and medication.
So true, George. Very well said. Now, let me ask you this next question, because what people are thinking about is, how do you do the follow-up? Now, you mentioned the PMP. We're both, Dr. Bright and I both practice in the state of Virginia, and that's how I came to know him from years ago. So what do you do for people? I'm sure you have referrals from out of the state. How do you follow individuals out of the state, and what kind of recommendations would you give for individuals in that regard?
What we try to do with the people out of state is to set up a program for them if they come to us, and they can be referred back to a local physician or mental health center in their community. As far as the PMP is concerned, most states require that, and we can get that from another state. If they are concerned about their young person using marijuana or other substances, they can almost always buy a drug screen in a local drugstore, and then do that intervention if that does come up to be a problem. Pill counts are something else that can be done, and parents should do that if they give the responsibility of the medication to their student. So those are just some of the thoughts that come to mind, but being sure that you have the right diagnosis is the important first step.
So true. So just to fill in for listeners, what happens is everybody in the state has to have permission to run a PMP in the state. So this would require, Dr. Bright knows this, but I'm just saying this for you folks, for him to get a PMP in Texas, for example, he's got to have a doctor who's in that to follow that whole state protocol, because they're not going to do it across boundaries. I mean, I've tried to do it, George, when I tried to follow somebody in North Carolina, and I learned that a long time ago because it just didn't work for me. What's your experience with that?
I find it to be even easier now with the drug problem that we have in this country. States are communicating with states. It didn't used to be that way. Mm-hmm. Because I think everybody wants to do one thing, is to do an intervention before it becomes a crisis.
Well, that's great. So then when they go back, do you do virtual follow-up? Do they come back to see you? How does that whole process over time? Do you have like a 6-month program, a year follow-up program? How does all that aftercare take place?
When they first come in, if they're local or if they're within a 2 or 3 hour driving range, then I would see them once a month for the first 3 months. And then if they were doing well, I would see them at 6 months. But we want to get them optimized with their medication as far as an ADHD medication is concerned. Mm-hmm. If they have a substance abuse problem, they're seen once a month for 3 months, and then every 2 months for a cycle of 3, and then every 3 months. And that involves the people who may be on a buprenorphine product for opiate dependence. If they're on a Vivitrol injection, which is a 30-day injection, then they come back once a month for that injection. And we usually recommend that for a year, because we feel it takes about a year for the brain chemistry to return to normal once they've come off alcohol and or an opiate.
This is fantastic, George. I mean, it's very, very useful. You have a great structure, and you have a great aftercare, and you have a view of that's a larger, inclusive view that really is comprehensive, and really a challenge. Now, do you ever have anybody? The thing that occurs to me right here is anybody ever run off from Blackwater? What happens with that?
We've had a few who have attempted to, but when you go out in the wilderness, you can't go but so far because nighttime comes. Right. But we've had referrals from London. We've had referrals. We had a young man from Australia. We've had referrals from throughout the country. But the real work that is done is not somebody who is going to be brought to the program by Bubba. We do not take kids that are escorted. Mm-hmm. These kids and these young adults have to be willing to get in the van and to do the program. Mm-hmm. And I've had people who've called back 15 and 20 years and said, George, that was the best thing that ever happened to me. I had a young man in here today who did the program in 2015. He's been clean for 15 months and just came back to say thank you because you gave me my first shot at the end of the trip of the Vivitrol, and I didn't relapse for 15 months. That's the reward.
Yeah, definitely.
And there are many, many stories like that.
So then, do you?
But let me just tell you what we find. Sure. You know, some of these kids that have been. I'm on the board of Caron Treatment Center, and I've been on there for 14 years. And they send us young people who are really not doing very well with didactic lectures. And what we found in looking at these kids, so many of them have an attention deficit disorder, but they also have a problem with what we call processing. And the right side of the brain is like a computer. It has speed. And so many of these kids just don't get it quick enough. They can think very quickly, but they can't process the information. Therefore, they're frustrated. And the more they're frustrated, the more they feel like a failure, the more they're likely to self-medicate. To identify that with a complete psychological evaluation, looking at the subtest scores of the left brain and the right brain, gives you a wealth of information to deal with that you can't really process and sitting in my office like I can once I learn the processing with an evaluation.
See, I think that's very interesting. I didn't know you were with the Caron Foundation. And for our listeners who don't know, Caron Foundation has been one of the serious thought leaders, their team, in terms of really working through issues that would contribute to substance abuse and relapse. And it's interesting that they're hooked up with this traditional psychiatrist who is using a stimulant medication. It says a lot about the evolution of the Caron Foundation in terms of their embrace of more modern thinking regarding the comorbid factors that could lead to relapse. It's very good. Now,
very true.
Now, let me ask you this, George. This is the other thing I started to get excited about. How do you deal with issues like depression and antidepressants, and where are you with that whole mishigas, which is yet another comorbid factor?
I think it depends on the family history. So many of these co-occurring problems have a genetic predisposition. So it's critical to get that family history, but also to really find why that person is depressed. Is it biological? Is it environmental? Does it relate to school? Does it relate to relationships? And certainly when you combine that with counseling, because you really do need that in-depth counseling with the limited time that we have as a practicing physician for medication management, then that combination of the appropriate medication, an SSRI or an SNRI, does help get them out of that depth of depression. But again, the diagnostic workup is critical, and then deciding whether to use and what medication to use in combination with the psychosocial support.
So we're running about a time a little bit here, George, and I want to tell you, first of all, thank you. It's great rekindling our relationship. We've met a couple times when Dr. Bright's down here in Tidewater, does a presentation. Try to show up once in a while, and that's been very interesting. And we had the chance to be together working out there when we were actually speaking on the Shire Circuit. Years ago, we'd bump into each other at meetings. But the real issue, the next issue, is how can people actually get a hold of you? I'm going to have it in the show notes, but if you would just repeat that connection again for the listeners who are in the car going to work, we can get that down, and then I'll put it in the show notes.
Sure. With the outdoor program, there's a website, www.blackwatoroutdoor.com, 804-378-9006, option 1. The Adolescent and Family Health Center is www.brightadolescent.com, phone number 804-794-8900. You know, Dr. Parker, I give all my patients my cell phone, and I'd be glad to give this audience my cell phone, which may seem a little bit unusual.
You can do it if you want to. You're the man.
804-564-6068. You and I have known each other a long time. I'm up in the years, but I'm passionate about what I do every day. I love to go to work because I love to see change in people. Mm-hmm. But, you know, when in this country we look at the negatives too much, our approach, and we do have 2 therapists, 2 psychologists, and I'm just a little country doctor from South Texas. I try to look at the asset because all human beings have strengths. All human beings have weaknesses, relative weaknesses. But to get through life, you look for those strengths, and you help those young people develop those strengths with a wraparound of family, support systems, and medication, and what we can bring to them to help them continue to grow and develop.
Well, that's why we get along so well, George. I couldn't agree with you more. And it's really interesting how often people pathologize these things and just get stuck on the negatives. This is bad, that's bad, this is addiction, whatever, instead of, hey, here's an opportunity to really grow from this experience and really make something out of it to change your life. And I think it's really absolutely wonderful that you're closing on this thought, because that is the future of psychiatry right there. It's a reason for our team at Core Brain Journal to talk with people like yourself, because you're taking it down to a completely different level than really, it's not the standard of care. The standard of care is to have a problem and make it a problem and stay with the problem and not really adequately emphasize the solution aspect. So thank you very much, George. I really appreciate your being here.
It is my pleasure, and if anybody has any interest in some of the things that we use for screens or the outdoor program, we'd be more than happy to talk with them and to be of help in any way that we can. And I really appreciate your letting me do this tonight. It's been a pleasure to talk with you, and hopefully the audience got something out of it too.
I'm sure they did. Hang on for a second when I turn the recorder off, because I want to talk to you about something else. So thank you, George. Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.